work?
Well, we'll find out. Let's see if anybody jumps on.
Okay, it says now playing on my thing.
Okay. It says live on my end.
Yeah, but I don't know why I'm not. It's still saying waiting for Tala Talks NICU. Oh, there we go. It's still saying. Oh, it's just delayed. Talks NICU. Oh, there we go. It's still saying. Oh, okay.
Yay!
We're live. We
Oh my
did it,
gosh,
Jen.
figured it out. Yay!
No delirium here.
Well, maybe. We'll see.
Or
TBD.
maybe. Okay, let's just give it a couple of minutes.
Sounds
Are you in Denver? Are you back in Denver?
Yes, back in Denver. Just got back last night. So
Was it
yeah.
fun? Was it a fun trip?
Yeah, had a good time. We took my brother-in-law to Disneyland and Universal Studios, and it was a lot of fun. We had a great time.
That's so nice.
Yeah.
Okay, we've got a few people on. Hi, Renard. How are you doing? I'm so glad that you can join us. So today, amazingly, Jen and I figured out how to do a live chat with more than one person. We figured out it has to be on the mobile phone. It can't be on the computer. And you have to be vertical as well, apparently. So these are all things that we knew, that we learned. So Jen is a neonatal nurse practitioner. And I know that you have lots of other letters as well. We worked together about 10 years ago now, and we were very good friends and stayed good friends. We've both moved to different cities. But Jen is one of those people that just makes stuff happen. Like if she recognizes that something's missing in the unit, she will create protocols and get people moving and will not stop until it's done. Very, very inspirational person to work with. And right now in Denver, or over the last few months at least, she has been working on the concept and prevention of delirium in the NICU. And that's really what we're going to talk about today. And it's a very new concept in the neonatal world, although obviously in the adult intensive care world, this is such a massive deal. And we're going to be talking about that more today and how it applies to the NICU. So Jen, I know I gave you a brief introduction, but can you just kind of fill in a few details, who you are, where you work, everything?
Yeah, totally. So I currently, as Tala had mentioned, her and I work together in Phoenix, back at Phoenix Children's Hospital. I currently work at Children's Hospital of Colorado. We are a large surgical unit. We do have a MFCU where we deliver high-risk moms. We have a BPD unit, and that's actually the patient population I work mostly with. So are babies that have long-term ventilation requirements due to being born mostly premature and have lung disease that is out of normal, out of the normal proportion of disease. So I have been there about 5 years, and never in a million years would I've ever found myself in this population. But it's one of the focuses is family-centered care, and anybody who's ever worked with me knows that that's one of my big things is family-centered care. So I jumped on that team and have learned so much. And I'm actually the lead nurse practitioner called, it's an APP subject matter expert is the appropriate title, which I think seems funny, but yeah, so this is something I'm very invested in. And that's actually how I became a part of a multidisciplinary group helping for the prevention of delirium.
So that's so cool and so impressive. So you work with like a lot of trach G2 babies,
Yep.
that kind of transition between empowering parents to get them home, letting them feel that they're capable of doing all the cares. You know, when we send babies home with trachs, it isn't just the logistics of like the vent and making sure that you can suction. It's also all the other things like being able to move the baby into and out of the crib and how to bathe the baby and all these other like little complications that the parents have to feel very comfortable with. So really, it is family-centered care. It is absolute pinnacle. So I guess with that, you are working with babies that have been in the NICU a really, really long time. And, I know from the adult data, obviously, the longer that the adult patients spend in the ICU, the higher the risk of the delirium. Like, really, the two biggest risk factors are like length of time in the intensive care unit and
Yep.
mechanical ventilation in adult patients. So
Yeah.
I guess, first of all, why is delirium so important in the NICU population?
Well, I think to your point, like we know about it in the adult world. Like screening in the adult world, almost it's like you're admitted to the ICU, you're going to get screening for delirium. And it's actually kind of falling down the line. They do it in the CICU and the PICUs as well. So a lot of the data that we have extrapolated for the NICU actually comes from the PICU and CICU. But I think that the delirium, and for me, how I kind of like, okay, this kid is on a fentanyl drip. This kid is getting a benzodiazepine around the clock. Why is nothing working? Why are they still agitated? And I think for me and a group of us were like, well, what are we missing? And so that's kind of really what happened. And I just felt like, okay, or there's so much unknown in the NICU in general and what
Right.
what we're doing. And so this kind of took us down a investigation of, hey, what is delirium? And are we, we had a few patients that we treated with risperidone, which we'll talk about a little bit later, and they got better. And we're like, oh my gosh, like, what is
Yeah.
this? You know what I mean? So,
Yeah.
so again, but it's like treating with risperidone has its own risks, and that's not really the first thing we should do when we spot
Yeah.
delirium.
So,
Um,
first of all, can you just, what is the definition of delirium? Because for me, in the adult world, it's very much like a cognitive, it's a waxing and waning, like where adult patients, which is what I've always thought about with delirium. I feel like in adult medical world, we spend so much time discussing the difference between delirium and dementia. Dementia is like, it is continuous, it is not going to get better, it is a medical situation, whereas delirium can be this waxing, waning course, and it's normally kind of secondary to something. So, first of all, how do you describe delirium? And then, how would we recognize delirium in kids that aren't going to start talking about the 1989 World Series when you ask them a question about their grandparents or whatever?
Yeah. So I think I'm going to read just because I think it's important for us to know like what is delirium to your point. So I'm going to read it from the DSM-5,
Okay.
and this is not a pediatric. There is no pediatric DSM-5 for delirium. This is
Yeah.
just a general. So it's an acute disturbance of consciousness consisting of disturbance in attention, cognition changes, short time in course and fluctuating symptoms as a physiological consequence of a medical condition, medication, or intoxication. So
Okay.
again, your point, and from there, I can kind of talk about what does that look like in our NICU population.
Yes.
So I think the highest risk factors that our patient population have is so there's two different types of risk factors. There's the unmodifiable, and those are like what you're dealt with, and then there's modifiable. So I'm
Mhm.
going to start with the unmodifiable. Babies that are age less than 2 years old these are the highest risk patients. Developmental delay, invasive ventilation. If they have some kind of acute severe illness, have they had surgery? How long have they been in the hospital? Some of the data in the PICU is the delirium starts usually within 48 to 72 hours of admission in the PICU. And so like if you think about the patients that we serve, I think of the complex surgical patients, whether it's a CDH that's going on ECMO or a TEFEA that, again, is going to be hospitalized and maybe have a prolonged intubation. Our babies that were born anywhere between 22 and 28 weeks that are now at term corrected that still have an endotracheal tube in. So a lot of these patients that we see who have prolonged chronic courses are going to be those are unmodifiable risk factors, and those can't be changed. And so how do we deal with that? And I think that comes into the prevention side of things and the modifiable risk factors. Do you want me to talk about those now, Tala, or should we
Well,
wait?
I just wanted to say that, like, I'm like, when you first started talking about delirium to me, I was almost like a little bit disappointed in myself that this isn't something that like I thought about independently before, which happens a lot in medicine, where you're like, why didn't I think of that before and
Sure.
put that together? Because we were talking about this right before we went live, but I did do a year of adult medicine and spent some time in the adult ICU, and it is such a huge part of adult medicine ICU, like this concept of delirium. And I know that you're going to talk about this more later. You've alluded to it, but just the whole prevention thing, just being in the hospital, and it's, with the same four walls that you're in, you're medicated, people are coming in and out all the time. It is very easy to become, and we always kind of joke about it in adults, like, oh, ICU-itis or whatever. But your entire mind loses its ability to function properly. And
Mhm.
so these are the patients that like don't understand what's going on. And very often it is secondary to a surgery or a medication, or, whether it's alcohol withdrawal or whether it's liver failure, or, there are things that are making the cognition go off, and people aren't able to think anymore. And it
Yeah.
is these patients that are intubated, that are in the same place, that are not moving anywhere, and that are there for a long time. And those are exactly like our NICU patients,
Yeah.
So it
Yeah.
almost seems like, this is something that we should have considered a long time ago. Yes, we'd always put it down to, oh, that's just what ends up having to happen. And, obviously, the most important thing that we are worried about in the NICU, now that our survival numbers are so good, is we want a perfect developmental outcome. So,
Yeah.
literally, anything that we can do that can improve developmental outcomes as well as mortality, obviously, then
Yep.
we should be doing it. So, you already talked about the immodifiable factors. So, babies that are
Yep.
born early on the vent, we're doing everything that we can for them medically, but there's only so much we could do. So, what about the modifiable factors?
Yeah, so modifiable are our therapy teams are huge. Like, okay, are these babies in restraints? Are we over swaddling them and being like, okay, you can't move or do anything? So being immobile is something we can modify. What kind of sedation meds are we using, and are they the right medications for the baby and what they're going through? Are they experiencing some kind of drug withdrawal that we likely have created based on all of the medications that we have used for these babies? Is there something medically going on with them? Do they have a new infection? Are they hypoxic? Is there a new something new happening them from them internally that we don't know about? Because that could also be a problem. um, there's deliriogenic meds, benzodiazepines like our Ativan and Versed, clonazepam. Those have 3 to 5 times higher risk of delirium. So if you are on a benzodiazepine, that is single-handedly the one drug that you should avoid for these patients. And then the next highest one is a narcotic. And I think of how many patients do we use these meds on? A lot.
A
Um,
lot.
a lot.
Really
Yeah.
a lot. And a lot of times our hands are tied, and we'll come back to the medications afterwards, but obviously any medication that's going to affect you neurologically is more likely to end up with delirium, especially if you are
Yeah.
using it for a really long time.
Yep.
So can we talk about, like we said, in adults, we can tell, you go and speak to an adult and you're like, what time of the day is it? And they say April. Like, that's obviously, or, how old are you? And they subtract 10 years. They lose their short term memory, they use their long term. Like, those are very identifiable things. And I know that there are scales in adults. How
Yep.
can we look at a baby and tell that a baby has delirium?
That's it. So I'm going to give you like kind of visual things that we see. I'll do that first, and then I'll go in. There's an actual tool that we can use, that's been proven in this age population that we can use. But there's 3 different kinds of delirium. There's the hyperactive, and think of those are the kids that are losing their mind and you
Yeah.
can't figure on them. Then you have those that are the good patients. They're like chill, nothing's really going on, but that's actually more common than the hyperactive, but the majority of them are a combination of both. So, actual signs that we see, like one of the biggest ones, and I've had parents tell me this, it's like they're looking through you. Like no longer are they tracking you and looking at you, they're looking through you.
But that's a much older baby at that point, because
Uh,
obviously a 23
yeah,
weeker has its eyes fused. A
correct.
28 weeker isn't going to gaze.
Correct. So this is important. Thank you for bringing this up. So 37 weeks and up. So these are going to be for term corrected patients only, not the preterm
Okay.
patients.
Okay.
Yeah. So
But a large part of the prevention starts in preterm, though.
100%. Yeah. It starts
Yeah.
with like the developmental part of things and then just continuing that developmental care with therapies, etc.
Yeah.
The limitation in the eye contact is, did they used to engage with their mom and dad and holding, and all of a sudden they're not interested in the primary caregivers, could be primary nurses, therapists, etc. Are they just not really having quiet and alert states? Are they just kind of going from sleeping to angry, or are they sleeping too much? So that's kind of
That's
some of
similar to the adult world where they're just worried about that sleep wake cycle and how much
yeah,
that affects them, you know?
yeah,
And just, I mean, they say that put any person, meds or no pet meds, in like a dark room or a lit room all the time. And we also just lose like normal cognition just because that
yeah.
sleep wake cycle is so important.
Exactly, and that's one of the things that, and we'll spend some time talking about the prevention piece. But I just wanted to mention that it's called CAPD, CAPD, and it stands for the Cornell Assessment of Pediatric Delirium. So that is a score that the nurses do once a shift. So this isn't a one time, we're just going to look at the first set of cares and then give a score. It's cumulative throughout your shift. In our unit, we do it at like 5 and 5. Every unit's culture is a little bit different. But this has what's called anchor points, and it's a whole chart, and I've listed some references and sent to you, and I think you're going to share
Yeah,
that.
I'll put
Like,
those below.
yep. So those will be, there's several articles in there about the CAPD scoring. But what it has, it's done twice a day, and then they have anchor points depending on whether you're a newborn, 4 weeks, 8 weeks, and it goes all the way up in increments up to 2 years. So you're not going to be held accountable for something you can't do that should be developmentally appropriate at your corrected age. And the anchor points and the questions they ask are eye contact, purposeful actions, awareness of surroundings, communication, restlessness, inconsolability, activity in awake states, and then timing and responses to interaction. So the
Okay.
scoring goes through questions that are all about that. And, this is subjective. So like you and I may look at this and look at the patient and maybe get a little bit. So,
Right. Like
something
a
you
lot of scoring in the NICU. Yeah.
100%. It's that plus you take everything else that you can, what are the parents saying and what are the
Yeah.
primary
Yeah.
saying about the patient. So it's one piece of the puzzle.
Jen, how do you score communication?
Um, I don't have it right in front of me, but I could totally grab the CAPD score. It's actually just right over there, and I can kind of go through if you'd like one.
Well, no, well, just, I mean, obviously, a 38 weeker is not communicating.
Yeah, so it's signs. It's developmentally appropriate. So each
Okay.
one, could it be eye contact? Are they looking
Okay.
at wait from you? Are they tracking, etc.
And then is it kind of like the Finnegan or whatever, where the higher the score, the more likely you are that you
Yep,
you are delirious or
exactly.
in,
So anything.
withdrawing or whatever.
Yeah, anything greater than 9 would be concerning,
Okay.
concerning for that. And so at that point, you would kind of, there's steps like, okay,
Yeah.
we are worried about this patient. And every unit kind of has figured out how to do and trend and track delirium a little bit differently. Our unit is, our criteria is, if they are greater than 44 weeks and still on either non-invasive BiPAP or intubated and have been in the hospital for longer than I think 2 weeks, then we will start the scoring. But if we have a kid that's term adjusted and we're worried about it, we can start the scoring before then.
Yeah.
Uh, and really, I
So
think the scoring, it's like, hey, we're worried. Let's make sure we're doing all the preventative things.
So I know that we kind of talked briefly about the pathophysiology of delirium. I
Yep.
don't really want to get too much into the weeds there. I know that in the adult world, and before this, I read, more stuff about the adult world, just because there's like so much more literature in the adult world, but that it's all, kind of our usual inflammation and all these other things, let alone the metabolic issues. I don't know if you can put that in a nutshell over like
Yep.
very
I will.
quickly.
Yeah, there's 3 different pathophysiologies that are thought to cause delirium. Of course, it's not completely understood in our population. One is neuroinflammatory, so that's where the inflammatory mediators affect the CNS, as you mentioned. The next is oxidative stress. So this is going to have increased CNS metabolism or in conjunction with decreased oxygen, and that's going to lead to global CNS dysfunction. And then the neurotransmitters. So our CNS function is disrupted for the normal neurotransmitters, and so those three are the main pathophysiology. And again, if I don't want to get in the weeds any more than you do, there's a lot of articles out there about the logistics of that.
Yeah. So going to the neurotransmitters as well, I was reading a lot about how it's thought to be maybe, not enough acetylcholine or too much dopamine, which,
Yep.
traditionally we've all used so much dopamine for blood pressures and stuff. Like, there's just so much about dopamine that is just coming to light about, like, I mean, it's very tempting to never use it again,
Right.
basically,
Right.
but it
Yeah.
is all those. And then I guess I also saw quite a lot on serotonin as well, but that it wasn't as mixed about that. Like, too much dopamine is just not good for
It's
these
not good.
babies
Yeah.
at all.
Yeah.
So we kind of talked already about the identifying delirium and everything. And what you really said was, you touched on the treatment, but I guess the prevention is what you keep saying is the really key
Yeah.
part.
Yeah. So I mean, how do we prevent it? I think again, developmental care prior to term for these babies that are born preterm, and then just the breathing tube will be in, and how do we get them out of bed? How do we sit them up? And so. Having your therapy teams heavily involved with these patients, having an early mobility protocol that's safe as far as getting patients out of bed with that breathing tube safely, so that way because if you're 38, 39, 40 weeks, you should be doing things, not just laying in bed with a breathing tube. So getting them moving is a big part of that modifial of immobilization. Creating a day-night cycle, like how many times
Absolutely.
have an X24 weeker who's now 40 weeks, and it's like the nurses still have like the cover over their eyes and everything's dark, and it's like no, no,
Yeah.
no, no, we need to
That's,
change
I
that.
mean, I think that's such a key part of all of it,
Yep.
I
Yeah.
mean, I always think in the unit, just imagine being in the same four walls all the time, like the lack of stimulation and, especially, God forbid, those little babies whose parents aren't as involved,
Yeah.
that aren't getting that family-centered care, they're not getting held as much and spoken to and read to, and like massages and all these things that have just shown to make such a
Yep.
huge difference in developmental outcomes. Like,
Yeah.
we all feel like we're the heroes because, we're correcting the sodium and the calcium and we're weaning the vents. But really, I think what we're all learning over the last few years, that what's really making the difference with these neurodevelopmental outcomes is like all this like extra stuff. This just
Yep.
the family centered care, the therapy teams like you're talking about,
Yeah.
phenomenal nutrition, breast milk, like these are the things that are like really making the biggest difference. All that
Yeah.
stimulation, you know?
Yeah. Us as the medical team, to your point, like we are only one piece of the puzzle, and we
Right.
need the whole team. Like we doctors, practitioners, not one discipline within the NICU can do the best care. It's all of us as a team, and I've ever since we worked together in Phoenix, I've always felt that way, and
Yeah.
I continue. Like we again, and we have child, and I'll kind of go through all the teammates. So let me talk more about the preventative
Yes.
things.
Sorry.
No. So minimizing things at nights. When these kids get older, do we need to be doing cares every 3 hours? Do we need to be getting their labs at 3 a.m. because that's the unit policy? Do we need to get x-rays at 4 a.m.? Can we let them have an uninterrupted sleep at night? Because having lack of good sleep or short sleep it exacerbates the delirium. And getting the whole
So
team
just,
involved.
Jen, can I just ask a practical
Yeah,
question with
yeah,
that? So
sure.
say you have a trait kid that obviously is getting, if you haven't put in a G tube yet, then they're still getting gavage fed.
Yep.
So like, would you literally write the order? Like, like how would you do that to not feed them Q3 or Q4? Do you change the order for how often they get fed at night or continuous feeds at night? Like what are you practically doing at the bedside to stop those interruptions?
Yeah, so I think getting most everything done by 10 o'clock. So you're doing the bath and the weights and whatever. And because none of these kids are bottle feeding, usually these kids
Yeah,
are not at that point. Sometimes they are, and then we wouldn't be concerned about delirium.
yeah.
Um, so these are kids that you're connecting them to a pump. So cares are going
Right.
to be really more driven on when that kid wakes up
So
during.
literally you would write the order in the chart administer 80 mLs of milk via gavage upon waking? Like, how do
No,
you
that would
even?
just continue. So, like, whether the baby is sleeping or not, the nurses can connect the feed, check placement, you know what I mean? Kind of do a hands off type thing versus,
Okay,
going in and doing all of the things.
okay,
A lot of the patients that I work with in the BPD are on continuous feeds just
yeah.
because of the lung protection. But yeah, and it's more patient driven care in the nighttime than it is nurse driven care.
Okay. Okay, so just it is just like watching the baby's cues more and trying to really what we should all be doing in every patient in the NICU, which is the clustering of cares. I
Correct.
mean, really, I
Yeah.
mean, in a 23-weeker, everybody going in and whatever is just obviously not ideal. I mean,
Right.
as you already said, the sleep-wake cycle is such an important part of the whole of creating and preventing delirium, basically.
Yeah. Yeah.
Okay, so you were talking about like kind of cares and stuff. What else can you do to prevent it?
We getting a schedule, like putting us a dry. We have like dry erase schedules that we can write in, and so it's like if we know that mom and dad come in every day from 8 to 5, and we know that they're going to hold every day at 12 or 1, trying to put that in. If we know that PT is going to come in at the first set of cares, cool, let's put that in there. So that way, that we can try to create some kind of daytime activities for these
Yeah,
kids. Now, granted, it's not going to be perfect, but just kind of having something visual in the room that's like, okay, these are the things that we're going to do for an activity standpoint for this kid. We have child life that will come and help the baby and the family. We have music therapy.
I know.
Uh,
I love
there-
our music therapist.
I wish the
Does she
pets could
play?
come into the
Does she
NICU,
play the
but
guitar? What does she play?
yeah, we have a guitar lady. We have somebody who plays a harp that comes in, which is
Into the
amazing.
unit? She
Yeah,
carries her harp in?
yes,
That's
yes.
quite a heavy load. Does she have
I
like
know.
a trolley?
It's on wheels. Yeah, 100%.
Okay.
um, yeah, just and getting. I can't emphasize enough like getting the parents involved. We actually
Yes,
have a handout that we have created to say, hey, this is what delirium is, and this is what we're looking for, and this is how you can be a part of it. And in my experience, parents are like, oh yeah, oh thank you for, oh my god, I've been worried about this. Like, yes, I see this. So, really getting them to partner in with the group is very important. Um, and then
absolutely.
other things to talk about, like make sure we have all the right people at the table. Our therapy team does something called the gross movement assessment, and that kind of is a screening that we use to have an early indication for cerebral palsy on these patients, these high risk patients. And so if they are, then our rehab medicine team, which kind of follows these kids from a very long standpoint, like after they go out of the NICU, will come in, evaluate them to make sure, like, oh, is this kid have high tone because we're worried about increased risk of cerebral palsy, and are we on the right medications? And again, we're going to talk about the medications here in a little bit, but
Jen,
um,
can I just interrupt you for one
yeah,
second?
yeah,
Jan Semia, I don't know if I pronounced that, if it's a hard C or a soft C. She just wrote, I've been, and by the way, hi Renard Fawaz, and I'm vegan. And I'm so glad that you're here. But Jan Semia wrote, I've been a NICU nurse for over 40 years, and what you were speaking about is so important. I've been saying this for years to providers. Some are open to change, and obviously some more resistant. And I do think that it really is the bedside thanks, the bedside nurses that know their patients well enough that they're
mhm,
seeing these fluctuations of care. Like you're saying, you're a practitioner, I'm in neo. So we really are seeing these babies, once or twice a day or whatever. And delirium is such a waxing and waning course. So to your point, like it really is so important that the checks are being done every shift. It
yep,
isn't like, and they're constantly being able to refer back to that check at the beginning of the shift. Because, I could come in one day and the baby is like at its completely neutral point. It doesn't necessarily mean at all that the baby isn't suffering from something.
right, yeah, yeah. And again, having a primary team is so important. Yeah, and our bedside nurses, they're the ones that have to be at the bedside with these patients when they're losing their mind and they're frustrated, and it's like, what do we do and how do we help them? And that,
Yeah.
again, that, for me, I had one particular patient, and this was, I think I saw, talking to, I think somebody commented just now, like, change is hard, or it is. And there was a lot of resistance. You know what I mean? It took a village of us to try to move forward. But I mean, I remember this patient, very medically complex and very agitated. And of course, we were giving her the benzos and we were giving her
I
narcotics, and
know.
nothing
It's
was
just such a
changing.
catch-22. Right.
Yeah. And the exact thing that we were treating her for was probably making the delirium worse. And this mom said to me, she's like, Jen, it's like she's looking through me. And it's like this, her skin is crawling. Like, it's like, I don't know how to explain it or describe it. And that broke my heart. You know, like I was like, okay, we need to do things better. We need to do better. How can we do it? And to your point, for better and worse on my own time, if I see something that needs fixing, I'm going to rally the troops and try to figure out how we can, how do we do this? You know, how do we get the
Yeah.
right people at the table to
Yeah.
make changes?
Okay, so we were still going through prevention. We talked a bit about like family centered care, and then you were
Yep.
talking about the therapy team, and then you were touching upon medication.
Yeah. So some of the medications, we like, let's back the train up, right? Like, if we know that benzodiazepines and narcotics are not great, then what are there other meds that we can use? Dexmedetomidine or Precedex is a medication that we've been using quite a bit of, and that is IV. Like, that's something that can be used to try to take off like the
So
benzos.
absolutely, we are using it. I for whatever reason, I feel like in cooling babies, we've been using it quite a bit. I don't love it. I feel like it kind of affects the heart rate,
It
especially in
does.
those cooling babies.
Yeah.
But I agree, like you're kind of stuck. The other thing that worries me about Precedex is I feel like it's just relatively a newer medicine, and we don't necessarily have all the studies out that we have on the
Yeah.
benzos and the narcotics. So I also, it's not like I want to jump to something else. But I
Yeah.
agree, it's nice having, and I don't know if this is true at all. But I also do kind of think that if you are going to give a selection of medications, there's a less chance that giving a narcotic is going to have, like, it's better to give a bit of a narcotic and a bit of a Precedex, or maybe clonidine and
Exactly.
something else, rather than a higher dose, just because you're less likely to be destroying all the same neurotransmitters and everything. So, if nothing else, even if it's taking the edge off the other stuff that you have to give, even if it's not the full dose that like is
Yeah.
actually creating what you want with the Precedex, it's
Yeah.
probably still better by reducing the total amount of medications. I
Yeah,
don't
and
know.
so like for a lot of our patients, you know, these by the time we're getting to this point, they're on full feeds and tolerating feeds, but you know, needing prolonged ventilation for whatever
Yeah.
reason. And so we use clonidine like in acute phases, or a lot of our BPD kids who are acutely ill will switch to the Precedex. But we use clonidine and gabapentin are two of the medications that we use to
And
help with state control, and it does seem to make a difference.
so,
In
Jen, the Precedex you give IV drip,
Yep.
right?
Yep,
Right.
that is a
So,
drip. Yep.
what sort of doses of Precedex are you doing?
So the max dose that we tend to use is 1.2 per kilo. I
Mm,
think it's
that's a
milligrams.
lot.
That's
That's
the
a,
that's the max.
yeah,
But we usually start at like zero point 0.4 and zero point 0.5. But a lot of these kids, I mean, we don't start them on Precedex. We start them on clonidine as a okay,
yeah,
like when these patients are starting to get to 37 and 40 weeks, they still have a breathing tube in. And again,
yeah.
my population that I work mostly with is our BPD population. And you know, they're starting to want to be babies and they have this breathing tube in. And so, you know, we think about clonidine, we start at 1 per kilo Q6, and
Okay.
then go up to 2 to 3 to 4
And
to
how do you
5.
give that? How do you give the
That's
clonidine?
enteral. That's enteral. So that
Okay.
is oral medication, usually through a tube of
Yeah.
sorts.
Do you
To get,
remember when we were in Phoenix, we actually used clonidine patches as
yeah.
well? I
Yep.
like, especially if babies were like post-surgical,
Yep.
and that kind of worked really well. That was a very low, gentle thing.
Yeah.
Okay, so the clonidine and then gabapentin. I've not used gabapentin. How do you use that?
It's also an enteral medication, so this can be used. And actually, when I was preparing for today, I did find a couple of new articles. I didn't read them about gabapentin.
In
Um,
neonates?
yeah,
I
gabapentin
mean,
and
I mean, in adults, it's fantastic. I mean, for
yep,
certain types of pain, like
yep.
there is nothing that works better than it, and not like bad side effects, not aggressive or whatever. So that's so. How do you give the gabapentin? What sort of doses?
So we start that at usually 5 per kilo 3 times a day or every 8 hours. And that can go up, I think, to 15 per kilo. But again, thank goodness we have an amazing pharmacist that is a part of this
Yeah.
multidisciplinary group and has helped us with that. But that can be for visceral pain and also for tone. So if you have kids that have high tone, the gabapentin and clonidine also
Yes.
have those
Yeah.
things. And so we really try to steer clear of any of the benzos. We get a lot of kids transported in from other facilities, and they'll be on high dose of both benzos and narcotics. And so we do our best to try to wean those down and start the clonidine or gabapentin if they're not on those and optimize
And
those to
if
get them
those babies have been on like the benzos or narcotics for,
their whole
yeah,
month.
yeah. So how long does it take you to wean off? A long
Oh,
time, no?
it does. Yeah, it does take a long time. And
Like
again, we have
weeks.
amazing pharmacists. Yeah,
Yeah.
yeah, but
So
we
what about Jen, kind of going back to earlier, do you in your unit, like you've got a kid on the jet or the
yep.
oscillator or whatever, what do you give for those babies?
So for the smaller babies, I feel like fentanyl is what we use.
Yeah.
I think a lot of people are nervous to use Precedex in the smaller kids, but for me, I'm like, do
Yeah.
they need sedation or are we just trying to take them out of the picture? And I love Precedex, and I think we
The
started using
thing with
it back.
Precedex is though it is a drip. It is a
Yeah,
drip.
it is a drip. So again, if
Yeah.
you have a patient that's on an oscillator that's acute, we do not use any high frequency on our BPD patients, and so
Yeah.
we don't have that to deal with. But I mean, I think we get some of the smaller babies in the children's hospital when they need surgery, and they're usually really sick, and so we'll start Precedex at like 0.3. You know what I mean? Because to your point, can they have a little bit of narcotic and a little bit of Precedex instead
Yeah.
of a lot of a narcotic?
Yeah.
Um, and again, I think we know that benzos are not good in the preemie population. Like I think that has been well studied. And again, what do we do to save their lives versus this isn't going to be good for their brain? I think we're always thinking about
Right.
that.
Well, and also, I mean, not to take away from the fact that we don't want babies to be in pain,
Right.
and it is this like constant battle between the medicine that we're giving is not good for the brain, but oh my God, like we don't want babies to suffer and be in pain. And
Yep.
being in pain is not good for their developmental outcomes either, like where you
Exactly.
just are so overstimulated by stuff. The
Yeah.
thing that we love after surgeries is Tylenol.
Yes.
So we
Yep.
use that a lot. Obviously,
Yep.
acutely during surgery, and anesthesia is out of our control, and they love
Yep.
their whatever they're using, their
Yeah.
ketamine and their narcotics and their
Yeah.
general and whatever else. Although every now and again they are doing a lot of locals and spinals and whatever. But still, we'll get them over that acute. Maybe the first night with narcotics, and then basically the next day, if it is a G tube or a hernia or whatever it is, we'll try to switch over to Tylenol as soon as
Yep.
possible. And
Agree.
Tylenol is kind of crazy. Like we think of it as such a like silly over the counter, like what's it really, what sort of pain effect is it really having? But it's life changing in these
Yep.
babies. Like
Agree.
it seems to work so well,
Yeah.
you
And
know?
their pain is controlled with just that usually.
Yeah.
Yeah.
Yeah. Okay,
It's
so
really fascinating.
Precedex, clonidine, gabapentin are kind of the medicines that you try to use instead of the benzos and the narcotics.
Yep. And then another thing that we have been utilizing in our unit too is melatonin. You know,
Really?
yep, we use melatonin, and that's actually kind of like a first line before clonidine. Like if these kids are like starting to get really agitated, it's like, well, are they sleeping at night? And if they're not sleeping at night, let's give them melatonin to try to.
What's that's so interesting. What's the youngest like gestational age baby that you've given melatonin to?
They need to be term, right around term.
Okay,
And
so
again, you don't.
37 weeks?
Yeah, 37 weeks and up ish. And some of our pharmacists would feel better around 40 weeks, but again,
Yeah,
47 weeks, kind of
yeah,
same. Yeah.
yeah. And what sort of dose of melatonin?
It's 1.5 milligrams total, so it's not per kilo. It's
Oh,
just 1.5 milligrams.
that feels like a lot. When I'm like, post call, and if I've napped in the afternoon, I know I'm not going to be able to nap. That's my like drug of choice. I'll take
Yeah,
1 milligram though.
one
Like,
milligram,
yes,
not
I
five.
take what? No, I take like 1 milligram. Yeah.
just a little
I
bit.
don't even know if it's placebo, but but even that though, Jen, like but that even melatonin scares me. Like
Mhm.
I mean, it's clearly working in the pineal gland and stuff. Like it
Yeah,
does worry me. People have been using melatonin, what, 10 years maybe?
yeah.
Like I do worry about the follow-up stuff with that. But
Mhm.
again, in this situation, you're not just like a cranky 48-year-old that can't sleep at night. This is
Right.
like their neurodevelopmental outcomes with their sleep weight. Like you're
Yeah,
balancing a lot more. And so
100%.
it's definitely better to give something that seems seemingly benign. Hopefully it is. Hopefully
Right. Well,
studies aren't going to come out in 10 years, which we know that like a narcotic isn't good. That's so,
right.
and so obviously you give that enterally as well, the
Yep,
melatonin.
yep, exactly. And sometimes we give them, I call it an appetizer. It's just a micro dose. It's like a loading dose that you'll give around 5 or 6 p.m., which is 10% of the dose. And then at bedtime, like 9 or 10 p.m., you'll give a full dose. So those are the kids that maybe are a little bit more struggling with their sleep, nighttime, daytime cycling.
Yeah.
So we sometimes will do that as well.
Does it knock them out?
It helps them sleep from the nurses. Again,
Yeah.
nurses at the bedside, like, and I'll always have conversation. Like, I'm here to help guide the train. I feel like the bedside people are the ones that
The
really understand.
conductor. Yeah.
Yeah, yeah, they're the conductors of the train, and so I really it's having trusting the primary team and the families to have these conversations.
Yeah.
If
So
it's
all
the
of these, I mean, I what's the information on GABA? I feel like we use so much stuff off label anyway, but like melatonin in neonates, are there any studies or anything on that?
I
Gabapentin, you said that there were a couple of gabapentin articles.
There are, and I haven't personally read them. I know that they are safe and they have been studied, but I don't have the data. I can send you. I don't know if those articles are linked, but I'm happy to send them
I
to you
feel
so you
like
can.
she sent me, by the way, something like 50 references. It was very, very, very impressive amounts of research. It's really, I mean, obviously you had to do all of that to put this together. Okay,
Yeah.
so we are still to get us back on track. We are
Okay.
still talking about, were there any other things with prevention?
I don't think so. I mean, really, just having it's a team approach. It's
Yeah.
not. It's a team approach. I think that's the most important thing. And then, once you're getting close to term, start that day-night cycling. You know what I mean? Lift the curtains, open the blinds, turn
I
on the
mean, I
lights.
feel like we should be doing that a lot earlier. I mean, I think
Agree.
AAP is like kind of 34 weeks ish.
Exactly.
I mean, it's not great for like a 36 weeker to be dark all the time either,
Exactly. Yeah.
you know?
Yeah. Yep.
I mean, and I tell parents that as like even on discharge when they're going home, like, during the day, don't turn the lights off and turn the TV off or whatever else. Like
Yeah.
it's really important to start kind of setting that up, that this is the
Yep.
day and this is the night,
Exactly.
and everything
Yeah.
else. So let's say that we do have a baby, like you were describing earlier, the baby that you were saying was looking through their mother. You've diagnosed delirium. What do you do? You've passed the point where you haven't been able to prevent it. This is where you are. You've diagnosed delirium.
Yeah. So, I mean, at that point, after, we wouldn't just like, you have to, it has to take a couple of days. Like, you need to make sure all the preventative things are in place. And if you've done all those things and nothing is working, then risperidone is, it's an antipsychotic that we use. And not like, I think we've only maybe had to use it one time in our unit since we have started the preventative, once, maybe twice. But that's the medication. There's no FDA guidelines for antipsychotics and pediatrics. I don't even know if there's FDA approval in the adult world, but it's what
Well,
we use.
Haldol is the
Haldol is,
one, right? Which I guess it's the same family as
yeah,
risperidone. It's haloperidone or something, I think.
yeah.
Like that's
And
the
then,
one that, I mean,
yep,
that's what the ER docs are giving when people are stumbling around the ER, in
yeah,
exactly, in an
yeah,
encephalopathic delirium or something. Like
yeah.
that's used all the time. I mean, I felt like in my brief time in adult medicine that was just used a lot,
Hmm.
instead of trying to do all these preventative things of sleep wake and sleep wake
Yeah,
cycle and stimulation and music and whatever else. The
right.
easiest thing, as we all know, is to give a medicine. and be done
Yeah,
with,
just give a
right?
drug and make it all
So
better.
yeah, but that's kind of like the, the antipsychotic that's given.
Yep.
Okay, so how is that given? Is that intramuscular or
That is an enteral medication as well.
enteral?
So enteral. And I will say in the one patient I was speaking about, we after one dose, we saw an immediate change in her. Um,
Really?
yeah, and to me, it's like, okay, I'm sold. It's kind of like once you see something with your own eyes, you're like, oh my gosh. Now, I certainly don't want to give risperidone to everybody. And again, I think because that's why I think prevention is key. I hone in on that so much, is because this is a preventable thing. Sometimes it's not, but we have a lot of information and data on what to do to prevent it. So risperidone is given once a day, usually at nighttime, and it's not a lot. It's not on forever. You don't have to. Some babies need it for a week. Some babies need it for a few days. But again, you're continuing to track them
And
and
do
support.
everything else they need.
Yep, exactly. So yeah, and again, I've seen some babies that do need it. They're so behind the eight ball, they need it on for weeks, and then everybody's nervous to take the medication off because we're like, oh my gosh, what happens if he goes back to the way he was? But by that point, whatever the acute illness was, is it better? Because sometimes it can be that. It can be like, is this long-term patient had a new shunt placement, for example, on our babies that have IVH and ventriculomegaly, and then that has sent them over the edge. Or did they
Yeah,
have a new infection that they were fine, and then their body went through this entire inflammation process, and so it's
yeah.
usually and I think that's
Well, I
something
mean,
very.
in the adult world, when adults are diagnosed with delirium, their mortality, and by the way, like some ridiculous number, and I read loads of different numbers, but it's estimated that about 35%, but there are some studies that are like 80%
Mhm.
of adult patients in the ICU get delirium. So
Yep.
these aren't small numbers that we're dealing with.
No.
And if they've been diagnosed with delirium, their chance of mortality goes up like 3 times in the
Yep.
following 6 months. Like the
Yeah.
numbers are outrageously bad. Like as soon as your brain is being affected. So even if I can't imagine, even if this isn't necessarily an increased mortality thing, what this would do for just developmental outcomes, you know?
Agree. Yeah,
Um,
yeah. That data is still to come as far as like what do we know? Like what is the long-term effects of delirium? And I think you kind of said some of them, but in the PICU, what they know is there's a decline in cognitive function while they're from the ICU admission to discharge. So there's higher mortality rates. There's longer time on mechanical ventilation if you're actually
yeah,
delirium. You stay in the ICU longer. You're going to be in the hospital longer, which means you're going to have more, your hospital bill is going to be higher. And I think it's easy for us to extrapolate this data for the NICU population because this is a rapidly growing neurodevelopmental time.
yeah,
And so for me, I'm like, oh my God, it's probably even worse. Like we don't have
yeah,
that data yet. And,
yeah.
and again, I think this is so relatively new in the
Well, I
neonatal world.
think it's also
Time.
such an important concept because, I think that it's almost like a catch-22 when you get those babies that are so chronic
Mhm.
and, they're getting agitated. So what do you want to do? Put them in the dark and don't overstimulate them so they don't get agitated. Or like
Right.
they're not sleeping at night, let's give them another benzo. And then, then there's tolerance and then you're going up on the drugs. Like it is
Mhm.
so easy to get like this uh uh marhaba, how to go, you go all the way, like just from a baby that you're trying to make the baby better, and it
Yeah.
actually just makes it so much worse. So even if you don't completely buy into, and I'm not saying to buy into or not buy into because this is such a new field, the true concept of delirium, I think we all really need to take from this that a lot of the things that we're doing for these babies are making them worse from a
Yeah.
neurodevelopmental standpoint,
Yeah.
in the
And I
same way as it's
think,
making the adults worse.
yeah, and I think if you're giving a patient benzos and they are not responding to them the way you think they should, I think that should be a light bulb to
Trigger it.
you immediately. Yeah. If what you've been doing isn't working anymore, then you need to go back to the drawing board and kind of think about it. Like, hey, what does this mean? What are
Yeah.
we missing?
Yeah. I mean, I've seen babies, that like you're trying to wean their narcotics, and then they go into their withdrawal, and then they get, their high temps, and those chronic lung disease babies get so worked up, and oh, it's
Yep.
just so, it's
Yep.
so painful to see those little kiddos. It really
Yeah.
is.
Yeah.
um, where I work right now, we don't do trachs. But I
Mhm.
obviously, a lot of other places I've worked, we did them, and they just break my heart because they know
Yeah.
what's going on. I mean, they like at time of feeding, they'd kind of look over at their pump, like, "Hey, is anybody going to give me food?" Like, so it's
Oh
almost,
yeah.
yeah, like this kind of locked
Yeah.
in thing. So the idea that then they become medication dependent and everything is just so tough.
Yeah.
So we kind of covered long-term effects. Just before we leave, and we've got a few more minutes,
Yeah.
say, what would you encourage everybody in the unit if they wanted to set up some sort of program like this, or like bring more awareness to this in their unit? Talk through what you did and
Yeah.
kind of things that we should consider.
I think one of the things that I've learned in every hospital is probably the same. You have to have the right people at the table. And so we had, from a nursing representative, a clinical nurse specialist, we had a physician, we had myself as a nurse practitioner who was an interested party, therapy team, pharmacy, child life. We had all of the people that were going to be involved in the prevention of this at a table. Like, let's talk about it. What do you have available in your unit? Like, so for our hospital, the PICU and the CICU already had delirium prevention.
Protocols.
Yeah,
So
and protocols.
did you go and chat with the so pick when you say CICU, you're saying the cardiovascular intensive care unit.
Yep,
So babies
exactly.
with hearts, right? And then
Yep, exactly.
right, and then the PICU.
Yeah, and it's standard of care there for every patient to, have this. The CAPD scoring was already in our EMR, so that was helpful. There is, so again, trying not to reinvent the wheel of things that
Yeah.
are already present in your hospital system is a good starting point, and then just having the right people at the table. Because if you don't have buy-in from your bedside nurses, this isn't going to happen. Can tell you that. Just in general and in my career, but also the therapy team is huge, and I think every unit's like or dislike of our therapy team is very different. But very, very important to have them be a part of this because mobility and immobilization, you need to not
That
be immobilized.
it's
Yeah.
I always think it's like the biggest change maker. the
Yep.
the
Great.
the therapy teams, they're amazing. I feel like the head butting comes with speech therapy, and I always talk about this. We've talked about this in the past.
Yep.
Like,
Yep.
we are coming at it from different places.
Yep.
We are coming at it from the fact that we want to get our babies eating and we want to get them home. They're
Right.
coming at it from the fact that they want this baby to be the safest possible eater so that there's no risk of aspiration. And
Yep.
so obviously, like, we're going to butt heads a bit, So it is,
Totally.
it's just
Yeah.
a setup for it.
Yep.
I
Yeah.
love the speech therapists that I work with, and I completely understand that we both have to give and take a little bit with that,
Yeah.
So
Yeah. But having like our PT and OT teams and developmental specialists, if you have those in your unit, is super helpful. And then, outside of the unit, do you have a psychology team? And again, NICU delirium is very, it's new to everybody. So oftentimes we'll contact whoever's on call for our psychology and they're like, what do you want us to do? But again, it's educating the people and you might find somebody that's like, oh, actually, I'm really interested in engaging in this and want to learn more about it. And then again, we have a rehab medicine team that really works on tone issues. And so we have collaborated with them as well. So I think, again, getting the right people at the table, because when you do big changes like this, you can't just have like a couple of people in a silo being like, I think this is awesome. You really have to have the right people at the table to make big changes like this happen.
Yeah, God, I mean, that is just such a great thing overall for cognition, for all. Like, I feel like there is so many points that you brought up today that are just so key, like even for a 30 weeker or a
Mhm.
34 weeker,
Yeah.
I mean, I keep hearing and reading articles and podcasts and conferences where people are like, look, we're really good at keeping babies alive. Our nutrition is really good. We're getting babies extubated. We're doing all this stuff. And it's not like a 30 weeker is going home and like not having any learning disabilities or behavioral. So
Yeah.
everything's not great yet. And
Right.
so this big piece really does seem to be this developmental outcome, where the developmental cares, the family-centered care. I mean, I tell families all the time that probably the most important aspect of like their kids' outcomes is going to be that first year after they leave the
Mhm.
NICU. Are you going to get in with all the therapists? Are you going to give these babies the stimulation and everything that they need? Are we going to keep those babies out of hospital? You know,
Yeah.
yeah, I mean, I'm in Texas where we have a measles outbreak at the moment, which Jen
Scary.
knows how I feel about that. But
Scary.
yeah, like all these things are just, you know, all these things just make such a huge difference in these babies' outcomes. Like not
Yeah.
just the exact number of days of intubation, not, you know, whether we're closing the PDA or not, or whatever, you know, all these things that we argue about all day and all night medically. How many days are we going to treat the clinical sepsis that we never got a culture in? Are we going to treat 5 days? Are we going to do a 36-hour ruler? Like all these things that we talk about all the time.
Yeah.
Really, in reality, it's obviously we need to take care of the baby medically, but
Yeah.
it's all this other stuff that seems to really be making the difference and the
Totally.
neurological outcomes of these babies.
Yeah.
So are you collecting data on, are you doing it as part
Yeah.
of a study, or like, I want to read about this, Jen.
So right now, and this is thank God we have our clinical nurse specialist because so I reached out to her. I'm like, hey, what are we collecting? So right now we're tracking like efficiency of CAPD scoring. So like if we have and we have an order set we've created that has like all the preventative things. Please minimize the activities at night. A lot of the prevention stuff that I've talked about, we created an order set for. And then we're also tracking the number of scores that are greater than 9. So those are the two things that, from a data standpoint, we're collecting. We meet monthly as a group to try to like, hey, where are we at? What's going on? I think there's also some audits that they're doing as far as, hey, is the room day night cycling? Is the iPad on 24/7 playing music? Or do we have it, do we have some pause periods around that? There's some patients that if I'm taking care of them and they're not quite at that 44-week mark, I'm like, if we're worried, let's start it. And, so I think we're also kind of, continuing to not officially track that, but like, oh gosh, we're starting to have a lot more kids at 42 weeks. Should we maybe change the criteria? But also
Yeah.
our unit is huge. And so like, we
How many
had to,
beds? How many
oh,
average daily?
lately, I feel like it's been 70. It could be
Okay.
more. I think that we can, every place can expand their numbers when needed. That's how.
Yeah.
But I think
Yeah.
between 65 and 80 seems to be our usually daily census.
Yeah.
So
That's a
it's a pretty
lot.
big.
And then how many kind of like, and that's children's hospital, so you don't have like the 23 weekers in that unit?
Correct. Yeah, unless
Yeah.
they. Well, we do a lot of oh my gosh, twin to twin transfusion, the SFLPs
Okay.
surgeries unit. And so we do have a lot of like twins that are premature that delivered if they're being followed there. But yeah, the
Yeah.
majority across the street at our, level 3 unit.
Yeah. Yeah. So that's nice. You get like the both sides of that as well.
Yep.
Yeah, that is a lot of surgical babies that you have. I mean,
Yeah.
basically most of them are surgical, right?
Yeah, I mean, we have two sides of the unit. We have one side of the unit, which is mostly surgical, and the other half is our like smaller babies and our BPD team.
Yeah. Wow. Well, I'm so excited to read about all of this. I mean, I definitely try to avoid giving benzos as much as possible, and then your hands are kind of tied. I've been
Yep.
nervous about giving Precedex in these little ones, and I
Start.
agree. I mean, we use fentanyl, but I don't know if that's great as well. And then I
Yeah.
always worry about fentanyl and the effect on the lungs, and I
Yeah.
mean, it's tough. We need a new
Yeah.
med.
Yeah. Well, I love Precedex. Maybe you'll,
You
start
do? You
those.
do love it?
I mean, I've loved it since Phoenix. I mean, we started using
Yeah.
it then. That was a long time ago.
Yeah.
We use it quite a bit. I mean, you're using Precedex on your cooling patients. Is that what I heard you say?
Yeah, and I will use it on, kind of uh, some sort of post-surgical if babies are bigger, like a meconium aspiration or whatever, that it would just keeping, from ECMO or that type of situation.
Yeah.
I will, but like not, it's not, I don't think about it routinely. And like I
Yeah.
said, in the cooling babies, I don't like its effect on the heart rate.
Yeah, I mean, because they're already cold.
Exactly.
Cool. So yeah, I would agree. But I think about it in the future. I mean, again,
Yeah.
it's for some of those kids that are bigger, post term surgical kids, we use it quite a bit.
So you would like literally a baby came back from surgery, you would put the baby only on Precedex?
No, 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 no.
Yeah.
Just in conjunction, yeah, but a
Yeah.
little bit. Like if you can use a little bit of Precedex and a
I
little bit of
agree. I agree. Anything to decrease the amount of narcotics. I agree. And then get them on the Tylenol. Like,
yep,
we use a lot of parental Tylenol
yep,
after surgery. I love it. Okay,
yeah.
Jen, anything else that you want to add before we go off?
No, no, but thank you for having me. This has been a lot of fun
Yeah.
and
I
around and available for questions.
Okay.
If
Does
anyone has
anybody have
any,
if you have any questions, then put them in the chat. But Jen, I really enjoyed this. Like I love thinking of this concept in the NICU. And honestly, I think that I know that you were really talking about term babies
Mhm.
and obviously post term, but really a lot of these thoughts are just very applicable all the way through our NICU babies. We should be doing whatever we can. The very young ones, it's trying to avoid noxious stimuli. I
Exactly.
think is the main thing. Encouraging skin to skin, family centered cares, like all of that stuff. But then as the kids are getting bigger, I think there are just so many lessons that we can learn about how to create a better environment for them,
Yeah,
so that
exactly.
they don't end up with delirium when they're 37 weeks. I mean,
Exactly.
that's the key thing.
Yeah, exactly.
Okay. All right. Well, I'm sure if anybody does have questions, then I'll get them to Jen. But again, thank you so much for being here. Thank
Of
you,
course.
everybody, for joining us today. This has been great. Bye. Bye. Now I don't know how to turn it off.